new episode of our podcast, The Doc is In. Today, we'll be focusing on life after stroke. So, my name is Victoria Mifsud, and I'm a consultant neurologist here at Cleveland Clinic Abu Dhabi, and I'm also the director of the stroke program here. I'm pleased to introduce to you today Dr. Sabahat Wasti, who will be joining me on this podcast. He's a consultant neurorehabilitation physician, and he leads the neurorehabilitation program here at Cleveland Clinic Abu Dhabi. And he has a vast experience in this field, and he is well known internationally. So he's the best person to join me for this topic.
Thank you very much. Thanks for that introduction.
We all know of people who have had a stroke, because we know it's a very important and common disease, unfortunately. So in your more than 20 years of experience in dealing with the field, how do you find that it affects people the most?
Stroke is very common. As you say, we all know someone who may have had a stroke. It is the second cause for mortality and third leading cause internationally for disability. However, before we actually delve into the details of how it actually affects the stroke, it perhaps will be useful for our audience to understand what exactly we mean when we are saying stroke. So, as an acute stroke physician, can you just elaborate for them what exactly stroke is?
Yes, it's true. Because sometimes people don't necessarily think of the brain when you're talking stroke. So effectively, a stroke is the damage that happens to a brain when blood supply to the brain is interrupted in one way or another. There are basically two major types of stroke. In the smaller percentage of strokes, a blood vessel which actually carries blood to the brain bursts and causes bleeding either into the brain or over the surface of the brain. But much more commonly than that, an artery which takes blood flow to the brain and therefore carrying oxygen and nutrients with it actually gets blocked. So a clot blocks an artery. There's not enough blood flow, not enough nutrient, not enough oxygen, so that part of the brain it supplies dies off. So, of course, since there's damage, that part of the brain won't work anymore. So, would you like to tell us something about the physical effects and how it actually affects a person?
Okay, well, thank you for that description. It hopefully has clarified how stroke happens. So, once the circulation is disrupted, which means that the circulation, either because of the bleeding or because of the blockage to the blood vessel, is not getting to a particular part of the brain, the effect of that event or insult is usually dependent upon what part of the brain has been affected. So there are lots of effects that stroke can produce, and patients can present with a lot of things, like they may have problems with vision, they may have problems with sensations, like they may feel numb on one side of the body or their face. They may have problems with speech as a presenting symptom. They may have difficulty moving their upper or lower limbs or both on either side of the body. And they may have problems with swallowing. So there are a variety of ways that stroke can affect a person. And it is important that very early, when these symptoms begin, that the patient or the person who's experiencing them are treated. As an acute stroke, several interventions or treatments have been sort of evolved over the last decade or so, which has changed the way the stroke is treated now. And it's made a little bit life easy for us, rehabilitation, because some of the time the stroke can be aborted and the effects can be reversed. So why don't you tell us, as a acute stroke neurologist, what is that you can do in the first few hours when these symptoms begin to occur, and how you can help the patients to salvage the brain?
Yeah, absolutely. I mean, this is the part about stroke that is really closest to my heart. The reason being that it's really the one and only opportunity we have to perhaps limit the damage and therefore limit the effects on the person. So it's really important for everyone to know that we can only really do anything active to try and reverse the stroke in the very, very early hours. So, and primarily this applies mostly to the types of stroke I mentioned, where it is a clot blocking an artery. So since it is the clot which is blocking the artery, what we want to do is try and somehow break down that clot so that blood flow is restored to the brain before too much damage happens. So for most situations, if the person arrives within 4.5 hours after the symptoms began, or at least after they were last known to be normal, if the scans look right, we can actually give them medication in the vein to break down that clot. And if the clot breaks down, the artery opens, blood flow is restored. The damage that has happened, but it doesn't continue to worsen. In some cases, it's a very small artery that is blocked, and you can't do anything more other than this medication. But in some cases, it's a large artery that is blocked. So when we actually do certain scans, like a CT angiogram, which shows all the blood vessels going up to the brain, you can actually see a big vessel is blocked. And again, if the imaging is right, and if you are there within 24 hours from when the symptoms began, then it is possible to actually have a small intervention, a sort of like it's done like an angiogram is done. They go in through the groin with a pipe, with a catheter. They can go up to where the artery is blocked, and the clot is actually pulled out. And again, blood flow restored, damage limited. But extremely important, this has to be done as early as possible. Just because it could be done within 24 hours, it doesn't mean that it's fine, we can wait. No, if it's done within 1 hour, it's much better. The outcome is much better and more successful than if it's done at 20 hours. So this has revolutionized stroke completely. The only problem is that despite our best efforts, not everyone comes in time. In fact, many do not come in time. Or even though you do the interventions, they may not be successful. So despite that, many people still remain with disability, unfortunately, or at least with impairment. So how do you deal with that in the first few days?
Okay, so stroke rehabilitation is a very important component of acute stroke care. Before I go into that, I just want to re-emphasize, because it makes our life as rehabilitation doctors much easier, that the families and the patients are vigilant, and as you have just said, they need to come to hospital at the earliest after the onset of the symptoms, so you folks can actually try and prevent larger disability or impairment happening. So in the unfortunate circumstances is where the stroke does cause impairment that cannot be reversed, where, for example, if somebody has had a weak arm and somebody has had a weak leg or a problem with speech, or so despite the wonderful treatments that you offer, there are still patients who unfortunately are left with significant impairments. And when we say impairments, that means the effect on the body part due to the dysfunction of the, or malfunction or lack of function of a brain. So if a part of the brain that controls the upper limb on the left side is affected, then the left upper limb will be weak, and we have to work to try and restore function for that. If the leg is affected, then we have to, as a rehab team, work to restore function in that. But we have other impairments like speech. Patients lose their speech. They may have lost some part of their vision. They may have problems with swallowing. So we have to work on the whole of that spectrum of as a rehab team. Now, what has happened in the last decade, that we have learned that the brain has a tremendous power to relearn or offset the effect of stroke if we start challenging it to restore function or activate the function again. You maybe switch on the function again, if you may, as early as possible. So we, as a rehabilitation team, now like to get involved within 48 hours maximum of most stroke guidelines, international stroke guidelines will tell you that the rehabilitation service should get involved no longer than 48 hours after stroke. And as I said, we offer different modalities of treatment: physical therapy, occupational therapy, speech therapy, and then the physicians like us who support the therapy team and the nursing team in getting patients better keep a very vigilant eye to prevent any complications that can make the patient's stroke status worse. Might it be due to other associated condition like blood pressure not being controlled well or diabetes not being controlled well? However, there are also concerns for the stroke itself getting worse. So, as an acute stroke team, you support us with that when we are treating the patients for rehabilitation. So, can you just tell us how you support us as an acute team in preventing the patients getting worse during their early rehabilitation phase? That's very important.
Yeah, of course. So basically, once the patient comes to hospital with the stroke and the very first hours are over, immediately we start thinking about why did the stroke happen? Because we want to prevent a new stroke from happening. And you need to know why it happened to address that, at least as much as possible, right? So when we're talking about patients who have had a clot blocking the artery, right, so what we call ischemic strokes, normally we would start something to try and make the blood cells less sticky. We call them antiplatelets, things like aspirin, clopidogrel, that sort of medication. But then we have to start looking elsewhere. So one important cause of stroke can be narrowing of the artery in the neck, for example, so carotid stenosis. And sometimes that only needs medical management, but sometimes that might actually need either a surgery to reopen the narrowing or stentings, again, putting in something to open up the artery, but non-surgically through an intervention, neurointerventionally. Another very important place to look at is the heart. So an extremely common cause of strokes, especially in the elderly, is something called atrial fibrillation. This is where the heart beats irregularly. And because of this irregularity, some of the chambers of the atria, the upper chambers of the heart, don't empty as much as they should, so clots can form there. So if a clot forms in the heart, then as the blood is expelled out of the heart to the rest of the body, a clot can fly to the brain, lodge there in one of the arteries, and cause the stroke. So if we do discover atrial fibrillation, then antiplatelets, the things we mentioned, the aspirin and the clopidogrel perhaps, are not maybe the best treatment, and instead you need actual blood thinners, things like warfarin or the newer blood thinning medications. So it's very important to discover this. And we check for this while the patient is in-house. Another thing we do is look at the heart by ultrasound, by echo. We do echocardiogram, again, to see if there's some structural abnormality in the heart, which also might alter our management. In the meantime, very, very important, of course, we check if they're diabetic, we check if they have high cholesterol, we check if they have high blood pressure, and all of these need to be managed and controlled, And usually, working that up takes a few days, and whatever we find, we address. Sometimes you'll find a hole in the heart, for example, and although it's actually common in normal people, if it's a young person and there's no other reason for it, you might need to have it closed. So we look for different potential causes which we know of, and whatever we can treat, we treat. If we don't find a specific cause, we just control all the risk factors. But of course, after we've done our part and after you've done the acute rehabilitation, at some point in time, right, these people need to go back home. So how do you and your team support patients in this transition from hospital to the community?
Well, thank you very much for giving that information about how you support the patient with stroke to prevent any further damage to their brain through their period of early recovery. We continue from the rehabilitation perspective, so the role of our team in acute hospital, something like Cleveland Clinic Abu Dhabi, is that we need to have these patients become ready to go to the next level of care. And the next level of care, when we say that, could be either returning home, if they are that level of care, or going to another hospital which is specialized in providing extended period of rehabilitation for them to improve further. Most often, what we do in our setup in Cleveland Clinic, Abu Dhabi, is that we continue to provide physical therapy so that these patients can become more mobile or be able to be assisted with their mobility by their families with the help of getting in and out of bed, sitting up in chair, increasing their strength to sit up in chair, start to stand up, move around within there if they are able to do that, but then within their rooms and go to the bathroom and start participating in activities of their daily living like washing and dressing, do brushing your teeth. I mean, it sounds like a simple thing, but if you have a right hand problem and you can't utilize it and your left hand is not as effective because you're previously right-handed person, just brushing your teeth becomes very difficult. So we try and get them to get engaged again in all those activities. Those patients who have more complex problems like swallowing issues, we continue to feed them with supplemental way of feeding through like tube up down their nose into their stomach. We don't propose very early insertion of tubes directly into the stomachs, but if that comes, we can also facilitate that. Usually, we like to delay it up to 3 weeks. If the swallowing not recover, then we will move and do that. So this is all the supportive care and re-enablement care, if you may, that will enable them to return home or to the next level of care. So those patients who can be handled and managed and supported by their families, like if we can train them to get in and out of bed, even if they're not walking at this point, but they can be fed, they're feeding orally, their washing and dressing has been sorted, and one person can take care of them. Then the whole home is welcoming, like it doesn't have difficulties with access, and there are not too many stairs and stuff like that they have to negotiate. Then we facilitate a person to return to home because that's the best environment for a patient to recover in. It's a big psychological boost to be back in your own environment, within your own family, and then continue the rehabilitation either with the patient therapist coming to their home, but more better if they could go to a day place where they can get outpatient physical therapy and occupational therapy or speech therapy if it's what they require. If they are not at that stage and we find that it's going to be too difficult or onerous for the family to look after them, or they don't have home that can accommodate them. The bathroom is small, the wheelchairs cannot be turned around, the beds are not too high. So we then, in that case, recommend that these patients are taken to what we call post-acute level of care, post-acute rehabilitation. And there are several hospitals in Abu Dhabi that support us in that. So that continues, and their recovery continues. But of course, even after they go out, they have to be managed from the point of view of what we call secondary prevention. And that is an important part of their care. And the ball falls into your court. You support the patients in not having any further insults from stroke point of view, because add-on damage is a very, very dangerous thing for the brain. So how do we recommend them to be followed up in neurology stroke clinic? And when they come to you, what do you offer them? What kind of surveillance or assessments do you do at the point of when they return to you in the outpatient clinics?
Yes, of course. So it's true. We really do encourage all the patients as much as possible to return to clinic, because they do need to be seen medically as well as from the rehab side only. So really, I think our role at that point is to make sure that they're following all the rules, to put it that way. So at the time of discharge, we would have already advise them on which medications to take long term, like the antiplatelets or the anticoagulants we're talking about, to prevent new clotting. So we'd have already advised them on that, but we need to make sure that weeks after they've left hospital, they still understand that this is a long-term thing. This is for the rest of their life, and they're actually going to do it and continue. We would also have advised them at time of discharge, right, about the risk factors. And it's very important that they make sure that they understand they have to continue following up with their, primary care physicians to make sure their blood pressure is well controlled, to make sure the cholesterol is not only well controlled, but for strokes, we like it on the low side, to make sure the diabetes is well controlled. And we've emphasized a lot, at least I have from the medical side, emphasized a lot today on what happens when a clot blocks an artery, so what we call ischemic stroke. But even in the case of people with hemorrhages, where they actually bled into the brain, for example, taking care of these blood pressures, of these risk factors, especially high blood pressure, is essential because keeping low blood pressure prevents the next stroke. But apart from all of this, then there are lifestyle measures, right? So making sure that they're following a healthy diet, making sure that, some people would have recovered a lot, so they can exercise. So making sure that these people are incorporating exercise into their life. After all, some people recover almost completely, sometimes even without our help. They would have had maybe what we call a TIA, a transient mini stroke. So for these people, taking on exercise is a very important part of prevention, not only taking their medication. But another thing that we try to look at as well is we try and identify if people are developing perhaps some post-stroke depression. Because, after all, it's very common, isn't it? For people to feel down, frustrated, maybe a bit angry after they've gone through something like this. This is a big life event. So it's natural for people to feel this way. And it has been shown, that if you don't ask, it may be very difficult to identify that people actually are depressed. So that is one of the things that we do ask about in our in-clinic assessments. And if we feel that patients do have this kind of problem, then we refer them on as necessary, maybe to psychiatry or psychology, to get all the support that they need. Once that from our point of view, then it's more a bit of long-term surveillance. But then they need to continue following up with you, right? Because long-term, now they're at home, now they're with their families, so there's an impact long-term on both the patient themselves and families. How do you perhaps help set the expectations? Because perhaps people do improve, but some may not improve that much. How do you help them to live with that?
So indeed, it's those who improve and improve well, that's very welcome outcome, and we have to support them to return to a higher level of living, right? So that's the easier one. They get accommodated in their own houses, but then it's our job to have them return to work, have them get back into some sort of gainful life, get back to driving. So those sort of things we can support and help with in rehabilitation. Then there is a second tier of patients who moderately have improved. They still need some help at home, but then we'll also look at how we can eliminate that help and have them attend to their own needs as much as possible. And there are several things that we can do in the more developed societies or the countries. We have some things called assistive technology, which helps patients to sort of control their environment. They may not have to come out of their beds to close and open the curtains. That kind of stuff the technology exists, that, right? And also the powered wheelchair, if they require that, and train them to utilize that, or if they have good upper limb function but not so good lower limb function, self-propelled wheelchairs, train them to utilize walking aids, power walking sticks or walking frames. So we can do that. Then there is that very complex, thankfully not that many, but a very sort of critical group of patients who are really disabled, unfortunately, right? So they're the most difficult ones. And that's where we actually help the patients' families and try to lessen their burden in a way that they can attend to their needs at home in comfort and care that they require. And still get some elements of self-reliance into it, so they can be, if they are able to read sitting up, we set up the environment for them to read and also to prevent any further complications, because these patients are at risk of muscles getting tight, what we call contractures developing. The spasticity can cause a lot of problem. The pain, particularly in the shoulder joint, is a common issue. So we have to provide that continued supportive cares to prevent any sort of secondary complications to this patient. So it's a lot we can do in a continued care of a stroke patient in the long term. And the most important one is that we have to maintain them in their environment for as long as possible and have them functional for those who can remain functional for as long as possible. So that is primary. So having said that, stroke is, yes, it's a bad thing for a person to happen, but we can make a life reasonably, not, I wouldn't say comfortable, but pleasant for people to live within their own environment, and for those who have actually come out of it well to continue to remain very gainful citizens of and effective citizens within their own community. And obviously, secondary prevention continues to help us, in maintaining these patients out for good for a long time.
Yeah, thank you. That's great. So, indeed, I really feel that stroke care has been revolutionized really and truly over the past 10, 20 years. I remember the time when they would say, oh, he's had a stroke, put him to bed and give him an aspirin. You wouldn't dream of that today. And the final message that I really must give to people is that if you think someone is having a stroke, they must go to a stroke center, not to just any hospital, because only a stroke center can deal with this, and as soon as possible. And here at Cleveland Clinic Abu Dhabi, we are a stroke center of excellence designated by DOH. So I really want to thank you, Dr. Wasti, for joining me.
Much.
This has been a great discussion. I hope that this has been instructional for the viewers, and I want to thank all of you for joining us. If you need any stroke care, you certainly will find it here at Cleveland Clinic Abu Dhabi. Bye for now, and thank you.
Thank you.